Sumandi, she got the link.
Okay. Okay.
She'll be joining.
Okay. It's live, I think. You can see it now. Live. So let us know when to start.
25 participants.
Let us have a green signal then.
Dr. Meenakshi.
Yeah, ma'am. Yeah.
Yeah, Dr. Meenakshi, can you call your members? Yes, जय सुमंदी स्टार्ट नहीं कीजिएगा.
बोलेगा ना. Mr. Sriman, can we start?
Yes, madam.
Can I start? Because
Yes, ma'am.
it's going live. Are we live now?
Yes, ma'am. We are in live. Yes, ma'am.
So shall I start?
Yes, madam.
Okay. Right. Good evening, Johar, Namaskar to one and all. I, on behalf of Ranchi Obstetric and Gynec Society, and also as president of this society, welcome all the esteemed faculties and the participants as well to the very important and a must-know reproductive abortion care training program, that is RAC training program, which is specially designed to benefit all the women across our country and has given the clinician a wider range to treat the patient. And for this, I'm extremely thankful to our FOXY President, Dr. Shanta Kumari, and Secretary General FOXY, Dr. Madhuri Patel, Madam. I'm also thankful to Dr. Ajay Sir for giving us this opportunity to conduct this training program for the members of Ranchi Society as well as for all the members from the northern zone of FOXY. Under this program, there will be 4 very important sessions, which is must-know sessions. Number 1, which I will be taking, that is MTP Amendment Act 2021, that is Medical Termination of Pregnancy Act 2021, what it is and what the amendment has been done, I will be dealing with. Then comes Safe Abortion Technique, which will be taken by another faculty, Dr. Meenakshi Kumari. And then comes WHO Saber Toolkit, which will be taken by another faculty, Dr. Asima Bharti. And then we will have last session on pre and post abortion of family planning counseling, which will be taken by Dr. Anuvi, all from the Ranchi Obstetric and Gynec Society. And now, with due respect to Dr. Ajay Sir, I need the permission to start my talk on MTP Amendment Act. So, just give me 5 minutes to share the slides. And please let me know if it is visible or not. Can you see my slides?
No, still not.
Click on the share screen button, madam. Then click on the share screen button, madam.
I have done that. Now, can you see?
Not yet, madam.
Huh?
Yeah, ma'am, it's visible.
Yes.
Visible.
Full screen, madam. Make
Okay.
it full screen.
Okay, I'll make it for you. That's full screen. Can you see now?
Yes, ma'am.
Okay. So I start with the first topic, that is module 1, and it is medical termination of pregnancy, MPP Amendment Act 2021, under respectful abortion care, which is a joint venture of FOXI and WHO initiative, and it is under Master Trainers Orientation Virtual Program 2022. So, what is the objective of this module? The objective is to know what are the new laws and what are the changes in this rules. As we all know that MPP Act was first formulated in 1971, and then there was some amendment in 2003, I think, and then this amendment, which is really very beneficial for our women across the country, took place in 2021, and that was formulated in March 2021 and came into action in September 2021. So, my next slide is regarding the unsafe abortions in India. As we all know that unsafe abortion leads to mortality and morbidity and hamper women and girls' full participation in their day-to-day life. It is a surprise to know that 8% of maternal deaths per year is due to abortion, and it is also the third leading cause of maternal mortality. And nearly 2 out of 3 of the abortions are performed under deemed unsafe environment, and nearly half of pregnancy-related deaths are in women and girls under 24 years because they are unaware of it and they don't want to tell anyone that they are going to have the abortion. Because up to 24 years, this is known as tender years for the women and girls. So when is abortion considered safe? What is safe abortion? When it is done by the appropriate method and when it is done by the trained person. So both the factors should be there, and it is not that if one factor is there present, then it is called safe. So it has to be there should be present both the factors. So what I was telling you is again written here that medical termination pregnancy amendment was done in 2021 for the safe and comprehensive care, which is mandated by law. So what are the modifications done in 2021? Modifications done in the requirement of provider. So previously what the Act had, there was requirement of opinion of one provider for MPP up to 12 weeks, and the MPP provider for 12 to 20 weeks was 2. So 2 providers are required for doing MPP between 12 to 20 weeks. Now, what this 2021 amendment says, it says that the requirement for opinion of MPP providers for termination of pregnancy up to 20 weeks of gestation. It means that one RMP can terminate the pregnancy up to 20 weeks, and the requirement of 2 RMPs is only required for the termination of pregnancy between 20 to 24 weeks. What is the benefit of this? Benefit is that this will increase the number of facilities doing MPPs, like in the public sectors, like many PSCs now will be eligible to perform the MPP services in 20 weeks, which is really very beneficial for our patients. of the law. There is modification for the vulnerable group of women. It means that women who are vulnerable can get MPP done even after 20 weeks. Earlier, the Act had the permission of MPP beyond 20 weeks only in cases where it was necessary to save the life of the pregnant women. But now, this MPP has been extended up till 24 weeks. From the limit of 20 weeks earlier, that too also when it was necessary to save the life of the women. But now it has been extended up to 24 weeks and to the special and the vulnerable categories of women. That we will know who are the vulnerable category of women in the later slide. And further enhancement has been done for the birth defect, which is beyond 24 weeks. What is birth defect? But those defects which is not compatible with life, but it needs the permission of medical board. So what is the benefit? It will increase the access for vulnerable women to safe and legal abortion services defined by rules. Committee includes violence victims, minors, among others. So now coming to the modification of birth defects and congenital anomalies, which I have already seen. Previously, it was said that this act had provision for termination of pregnancy only up to 20 weeks. Even if there was birth defect, we had the permission to terminate the pregnancy only up to 20 weeks. Now, this gestation limit has no limit. It does not have any upper limit in cases of congenital anomaly in the pregnancy with substantial fetal anomalies, which is diagnosed by the medical board. But mind you, we need the permission of medical board for terminating this type of pregnancies. What is the benefit? It will increase in access to safe and legal abortion services who often seek service late beyond legal limit for termination of pregnancy, because we all know even by they do regular ultrasound, they come to know about the congenital anomalies quite late in the pregnancy, maybe after 20 weeks, and then now they have the option to get the pregnancy terminated under law. So it will be safer for our women. It has been amended to increase the safety of our women. So one other modification has been done in relation to the marital status. Earlier, what was that? Only married women were allowed to get termination of pregnancy done in cases of failure of the contraceptive. But now it doesn't only applicable to married women, but it is also applicable to any women, married or unmarried, for the women or for her partner. So what is the benefit? The benefit is that it will increase the access to safe and legal abortion for any women, irrespective of their marital status, especially with upcoming changes in legal age of marriages, which is an important advancement for increasing access to safe abortion. Now, there is under this amendment, there is insertion of new clause for strengthening the privacy. So earlier also we're supposed to, we're not allowed to disclose the privacy of the women, and same this has been again implicated in this 2021 Act. So we don't have to disclose the name and the other particulars of the women who will undergo termination of pregnancy, and we have to disclose their identity only to the authorized person by law for the time of being imposed. If they demand, the authorized person, if they demand to know their particulars, we can disclose to them only. Otherwise, we have to keep it quite confidential. Why this has been done? To increase in privacy and confidentiality of abortion seekers, so that there will be increase in demand, but need to safeguard rights and dignity of women and provide respectful bias-free services, including counseling and contraception, so that they will go to the same place and to the same doctor to get the termination of their pregnancy done instead of going to unsafe places, because they are under fear to get disclosed of their status. Nobody wants to get their identity to be disclosed, especially in cases of unmarried women. So this is really a boon for all the women across our country. So again, by bold letters, it has been told that we have to prioritize the confidentiality and safety of our patients. The name and other particulars of any women seeking abortion to be confidential, except to a person who is authorized by law for the time being. And the ground of failure of contraceptives has not only been extended to women but also to her partner. So, what are the rules under MTP amendment? So, we will know and study the NTP amendment under three categories. Who are the vulnerable category of women who can seek permission of termination of pregnancy beyond 20 weeks, up to 24 weeks? What is the norm for the registered medical practitioner, and who has the power and function of the medical board? One by one, we will study. So, regarding this special category of women who are eligible for MTP between 20 and 24 weeks, number one are the survivors of sexual assault, which is survivors of rape and survivors of incest. Secondly, women who became pregnant in humanitarian settings like disaster or under emergency situations as declared by government, they are eligible for termination of their pregnancy. Number third vulnerable category is changes of marital status of the women during the ongoing pregnancy. Either they are divorced or they have become widow. They have the right to get their MTP termination even beyond 20 weeks of pregnancy and up till 24 weeks. Then number four category is women who are physically disabled, and the disability criteria will be under the Disability Act. Now, another set of women are those women who are mentally ill, including mentally retarded. Then comes another set of our minor children who fall prey to this sexual assault. And then seventh one is the fetal malformation, women carrying pregnancy with fetal malformation. Now, let us understand the norms for the registered medical practitioners. Who are the registered medical practitioners? As we all know, they should have a MBBS degree. Now, who can perform the MTP? All the medical practitioners who are MBBS and have assisted in 25 cases of MTP, of which at least they have done 5 cases independently in a hospital. Number two, those medical practitioners who has done their house job in obstetric and gynae for 6 months. Then all the medical practitioners who have a degree, postgraduate degree or diploma in obstetrics and gynecology. And number four, all the medical practitioners who have worked for 1 year in the Department of Obstetrics and Gynecology in a hospital. Now, under the same norms of RMP, another additional category of provider has been added. That is, who can terminate the pregnancy up till 9 weeks, and that too with the medical methods. This is a very recent category attached in this amendment rules. So, in this category, all the RMPs, the providers for MTP who has the experience in obstetric and gynae at any hospital for 3 months, even for 3 months, they can do abortion by medical methods of abortion, or they are on those MBBS doctors who has the training, the performance of 10 cases of MTP, who have done 10 cases of MTP by medical method of abortion under supervision of a registered medical practitioner in a hospital established or maintained or a training institute approved for this purpose by the government. But they have done the training under a setting proposed by the government, and on their own they have done medical method of abortion under supervision. So here also one even for this one RFP opinion is taken up for the 20 up to 20 weeks, 2 RFPs between 20 to 24 weeks, and beyond 24 weeks there should be permission from the medical board. So this is very beautifully so a chart has been given for the RFPs whose opinion is required for termination of pregnancy and different gestational age. We will know each one by one. So up till 9 weeks, experience in training is required for RFP. Up till 9 weeks, you can do up till 9 weeks. Any MBBS doctor who has experience at any hospital for 3 months in the Department of Obstetrics and Gynec can do termination of pregnancy up to 9 weeks by medical method of abortion, or who has independently performed 10 cases of MPP by medical method of abortion under supervision of a RMP in a hospital established or maintained or a training institute approved for this purpose by the government. Number 2, who can do MPP? A practitioner who has assisted a RMP in performance of 25 cases of MPP, of which at least 5 have been done independently by the same doctor in a hospital. He can also do MPP up till 20 weeks. The doctor who has a training for only 3 months can do termination of pregnancy by medical methods of abortion up till 9 weeks, but who has done the training for 6 months in the Department of Obstetrics and Gynec, or 1 year they have served in Department of Obstetrics and Gynec, or they have done assisted 25 cases of MPP, they can do termination of pregnancy up till 20 weeks. Now, a practitioner who holds a postgraduate degree or diploma in obstetrics and gynec can do termination of pregnancy up till any weeks. But after 24 weeks, they will also need a permission from the medical board. Number 4, a practitioner who has completed 6 months in house job, they can do also termination of pregnancy up till 24 weeks. Up to 20 weeks alone, and up to 24 weeks, they will need one more RMP, and beyond 24 weeks, they will need the permission of the medical board. Number 5, a practitioner again who has experience of in Department of Obstetrics and Gynec for 1 year also can terminate pregnancy up to 20 weeks alone, up to 24 weeks with 2 doctors of the same kind, and beyond 24 weeks by the permission of the medical board. I hope it is clear to all of us. Same thing has been repeated. That was for 9 weeks. So who can do 12 weeks? They can also do up till 9 weeks. Till 12 weeks also it is the same thing. Who can do for 12 weeks? Any practitioner who has assisted a registered medical practitioner in the performance of 25 cases of MPP, and independently he or she has done 5 cases in the hospital, they can terminate the pregnancy up to 20 weeks. Again, a practitioner who has a degree or diploma in obstetrics and gynec can terminate the pregnancy up to 12 weeks. A practitioner who has completed 6 months a house job in obstetrics and gynec can terminate the pregnancy up till 12 weeks, and any practitioner who has a training in Department of Obstetrics and gynec for 1 year can terminate the pregnancy up till 12 weeks. And here also up till 12 weeks, opinion of one RMP is required. Coming to the now for RMP, whose opinion is required for termination of pregnancy at different gestational age. Matlab, who can terminate the pregnancy from 12 weeks to 20 weeks. Again, the RMP who has a degree or diploma in who has a house job in obstetrics and gynae for 6 months, or practitioner who has 1 year experience in obstetrics and gynae in a hospital can terminate the pregnancy after 20 weeks, where opinion of only that doctor is required. That is, opinion of one RMD is required. Now coming to the termination of pregnancy between 20 weeks till 22 weeks. Let us see who can do it. Any doctor who has a degree or diploma in obstetrics and gynae, any doctor who has the house job for 6 months in obstetrics and gynae, and any doctor who has 1 year experience in the department of obstetrics and gynae. But here, any one will require a opinion of second RMD as well. Now, coming to the last part of it, who can do termination of pregnancy beyond 24 weeks? Again, who has a degree of diploma in obstetrics and gynae, and secondly, who has 1 year experience in obstetrics and gynae. Here, see, who has done only house job in obstetrics and gynae for 6 months cannot terminate pregnancy beyond 24 weeks. But if he has 1 year, he or she has 1 year practice of obstetrics and gynae in a hospital, can terminate the pregnancy and beyond 24 weeks, but he or she will require the opinion and permission of the medical board. For the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling at an approved place by the medical board. Now, what is how the medical board is composed, how it is formulated? So it will require a gynecologist, yes. It will require a pediatrician. It will require a radiologist or a sonologist. So what are the powers of medical board? The powers are to allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure will be safe for the woman at the gestation age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child, when born, would suffer from such physical or mental abnormalities to be seriously handicapped. And the board can co-opt other specialists also and ask for any additional investigation if required for deciding on the termination of pregnancy. So there's a one more that FOXI, with ministry guidance and WHO support as part of RAC, can operationalize and post medical board information on website. FOXI can declare the medical board information on the website. So what are the functions of the medical board? The functions are to examine the woman and her reports. So any woman who seeks abortion beyond 24 weeks for congenital anomaly reports to the medical board, and the medical board will examine all her reports and provide the opinion of the board in Form B with regard to the termination of pregnancy or rejection of the pregnancy for the request, and allow or deny termination within 3 days. By the time he or she gets the women approaches the board, he will have to answer within 3 days of receiving the request for medical termination of pregnancy. He cannot, the board cannot delay beyond 3 days, and they will also ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. Not only that, it will give the opinion within 3 days, but also they will provide the place where pregnancy should take place in a safe environment. And the FOXI has an important role to play in ensuring there are functional medical boards in every state. FOXI has to take a stand to see that every state state has its own amendment, MTP opinion medical board. Every state should have and every district should have, and this proxy has to very important role to play. So I think I've gone through all the important slides. They were very informative and in our day-to-day practice. And with this, I end the module 1. And I hope everybody has been benefited. And if there is any question, it can be taken up in the last part, in the end of the session. Thank you very much for your patient hearing. I'm stopping the sharing. So, second part will be taken by Dr. Meenakshi Kumari, our another faculty. I invite Dr. Meenakshi Kumari to take the session. She is practicing obstetrician and gynecologist at Ranchi, and her talk will be on safe abortion techniques. Dr. Meenakshi, are you there?
Yeah, ma'am.
Please start sharing the slide.
Starting.
Yes, we can see your slides.
Yeah.
Yeah, it's full screen now.
Good evening, everybody.
Yes, ma'am.
My topic is safe abortion. What are the updates in technology?
Can you be a little louder, Meenakshi?
Yeah, the session overview is existing guidelines, pre-abortion assessment, medical methods of abortion, and surgical methods of abortion. WHO has global guidelines on safe abortion, and WHO and many national publications on safe abortion also. This is Ministry of Health and Family Welfare National Guidelines on Safe Abortion, which is showing the rules are changed on 24 September 2021. Pre-abortion assessment and counseling. Component of pre-abortion assessment for women seeking first trimester abortions. First step is detailed history taking. Second is general physical and pelvic examination. Third is laboratory and other investigation. And fourth is decision-making information on abortion procedures and counseling. Pre-abortion counseling, we must first ask what are the thoughts about terminating the pregnancy and the reason for terminating, and should inform the patient that early abortion is safe, importance of trained provider performing the procedure for safety, available methods of abortion, risk and warning sign associated with the abortion method. Without contraception, she can get pregnant as soon as 14 days after an abortion. Resumption of her normal activities, including sexual intercourse and any other follow-up care. So document the informed written consent, decision to accept post-abortal contraceptive. Even if she is not willing for contraception, she will be provided with the abortion services. Clinical management of abortion. Abortion care in less than 12 weeks. There is global recommendation of using mifepristone and misoprostol only, or vacuum aspiration. And after 12 weeks, mifepristone and misoprostol only, and dilatation and evacuation. Dilatation and sharp curettage is not recommended any time. So until 9 weeks only, we are having option of medical abortion. Clinical management abortion, the method of first trimester abortion, there are two methods, medical methods and surgical method. The tablet mifepristone and misoprostol. Mifepristone, an antiprogestin which inhibits the action of progesterone. It interferes with continuation of pregnancy. Initial oral dose of mifepristone is followed by misoprostol, a prostaglandin E1 analog. Misoprostol causes cervical softening, uterine contraction, expulsion of product of conception. Protocols for mifepristone and misoprostol. On day 1, mifepristone is administered along with mifepristone. Anti-D is administered if woman is Rh negative. On day 3, mifepristone administered, misoprostol administered up to 7 weeks, 400 microgram misoprostol, 2 tablets of 200 microgram each, either sublingual, buccal, vaginal, oral, or 7 to 9 weeks, 800 microgram sublingual, buccal, or vaginal route. In addition, analgesics, antiemetics, and contraception is also performed. Within day 15, follow-up is done, and at the time of follow-up, confirm and ensure completion of the procedure, offer contraception if not already done so. Characteristic of different routes of misoprostol administration for first trimester abortion. Oral pills are swallowed and it is recommended up to 7 weeks. For first trimester abortion, side effect is diarrhea, nausea, fever, and chills. Buccal pills are placed between the gum and cheek and it is swallowed after 30 minutes. More fever and chills than the vaginal route is reported. Sublingual pills are placed under the tongue and is swallowed after 30 minutes. Increased fever, chills, diarrhea, and vomiting compared to the vaginal route, the fastest onset of action and highest plasma concentration level is achieved. Vaginal route pills are placed in the vaginal furnaces, which are the deepest portion of vagina, and the woman is instructed to lie down for 30 minutes. Pill fragment may be visible. It has lowest rate of side effect. Provision of MMA services. Services should be available at primary care level with referral systems in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortion, counseling and testing for STI, abuse support services, psychological or social services, or other specialist health or medical services. Provide iron tablet for anemia if needed. Provide any necessary pain medication. Provide emotional support. Follow-up care, routine follow-up, not necessarily following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive, counseling, and services, emotional support, or address any medical concern. A routine follow-up visit is recommended only in cases of medical abortion using misoprostol alone to assess the success of abortion. During follow-up, assess the woman's recovery and ask for any sign or symptom of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaints. Assess woman's fertility goal and need for contraceptive services if not provided earlier. The summary of MMA is on the day 1, physicians will do a physical pelvic examination, confirm the eligibility up to 49 days or 7 weeks of LMP, tablet mifepristone 200 milligram orally, offer anti-D to Rh negative women. Tell the woman return for misoprostol after 2 days. Contact address and phone number of the facility center where she can go in case of any emergency. Record her experience of any side effect on the MMA card. 3% of women may expel completely with mifepristone alone, but misoprostol schedule should be completed. On the day 3, give misoprostol 400 micrograms sublingual or buccal or vaginal or oral. Observe for 4 hours. Analgesics, ibuprofen 400 milligram. Contraceptive options, condoms, hormonal methods, oral or injectable. Tell the woman that mean period of bleeding is 8 to 13 days. Possible side effects are nausea, vomiting, diarrhea, headache, fever, dizziness. Report in cases of excessive bleeding, pain abdomen, and fever. Report if there is no bleeding. 24 hours after misoprostol administration, giving additional dosage of misoprostol. 75% of women abort within 4 to 6 hours after misoprostol administration. On the third day visit, that is day 15, do a pelvic examination to ensure the completion of abortion. Contraceptive options are hormonal, condoms, IUCD, and sterilization after 1 menstrual cycle. Tell the woman about immediate return to fertility. Report back if there are no period within 6 weeks of completion of the abortion process. Ultrasound only if examination does not confirm the completion of procedure. Side effect and complications. So respectful and non-judgmental communication, verbal support, adequate counseling, support persons should be there. Ibuprofen 400 milligrams administered. Persistent pain with failure to respond to these drugs for several hours warrants evaluation for other causes like ectopic pregnancy, infection, or incomplete abortion. Nausea vomiting is generally self-limiting, so reassurance is enough. Diarrhea is self-limiting, reassurance is enough. Infection confirmed by physical examination and start antibiotics. Action for failure or incomplete result of MMA. If it is failure of for vacuum or repeat MMA, incomplete MMA. Observe for heavy bleeding. If bleeding is resolved and uterus is normal size, then abortion is assumed to be complete. If heavy bleeding is continues, offer surgical method of abortion or vacuum aspiration. Excessive bleeding. Woman present with excessive bleeding PV, bleeding more than her menstrual cycle, soaking 2 pads in 1 hour for 2 consecutive hours. Bleeding decreases over time. Watch vital signs, PV examination, POC in cervical canal or distal evacuation. Woman is stable and bleeding continues. Then observe and monitor vital signs and bleeding PV for more than 1 hour. USG is indicated in minimum decidual beats. Wait and watch. Product of conception decidual beat. Woman is stable. Misoprostol 800 microgram oral or 400 microgram sublingual. Woman not stable. Vacuum aspiration should be done. And if there is continuation of pregnancy, then also vacuum aspiration should be done. Method of first trimester abortion, surgical methods, it includes MDA and EVA. Surgical methods, vacuum aspiration is recommended technique of surgical method of abortion up to 12 weeks. WHO recommends manual vacuum aspiration as safest method. The procedure should not be routinely completed by sharp curettage. Procedure of abortion performed is seen regardless of type of vacuum used. Manual vacuum aspiration, handheld aspirator is used to generate vacuum. Aspirator is attached to cannula of 4 to 12 mm in diameter. Cannula can be used in multiple settings, including those without electricity. IPAS or easy grip cannula size correspond with weeks of gestation, that is 8 mm cannula for 8-week gestation and 10 mm for 10 weeks.
Sorry, Meenakshi, just hold on a second. Manisha, can you mute yourself? Manisha, can you mute yourself? Manisha, can you mute yourself, please?
Calling, sir. I'm calling, madam, sir.
We are not able to mute her from here.
Yes, sir. That's the reason I'm calling, madam, sir.
Just call her and ask her to please mute herself.
Yes, sir. Yes, sir.
Thank you. Carry on, Manisha. Meenakshi.
Okay, sir. Electric vacuum aspiration is an electric pump used to generate vacuum, can accommodate cannula of manual vacuum aspiration with correct size tubing. Pain management for vacuum aspiration procedure, important component of quality abortion care, reduces pain and anxiety and makes women comfortable. 2 components of pain management are there, non-pharmacological and pharmacological. Non-pharmacological, providing psychological support, explaining each step to women in advance, performing the procedure gently and smoothly, encouraging the woman to relax and breathe deeply. Steps of MBA. Prepare the instruments. Ensure pain control medication is given at appropriate time. Ask the woman to empty her bladder and then perform cervical antiseptic preparation. Administer paracervical block, dilate the cervix and insert the cannula. Withdraw the cannula 1 to 2 centimeter away from the fundus inside the uterine cavity. Rotate the cannula in 10 to 2 o'clock position and with smooth gentle motion. Release the vacuum button of the aspirator. Signs that uterus is empty: red or pink foam without the tissue passing through the cannula, gritty sensation over the surface of uterus, cervix gripping over the cannula, uterus contracting around the cannula, or increased uterine cramping. Step 8 is inspection of tissue. Step 9 is concurrent procedure along with contraception method like sterilization or IUCD insertion can be done at the same time. And instrument processing: instrument to be soaked in chlorine solution, assist disinfection, helps remove tissues and body fluid. Post-procedure care: monitor her for any complication and provide management as needed. She may leave the facility when she is stable and meet the criteria for discharge. Ensure that woman has all necessary information and medications prior to leaving the facility. Document all outcomes of the treatment, including any adverse event, in the facility register and client's record card. Aftercare: management of abortion complication, incomplete abortion, infection bleeding, ongoing pregnancy, provision of contraceptive information and offer contraceptive counseling and method, assessment of any other sexual and reproductive health needs that may require additional care. Follow-up: no routine follow-up unless meso-alone regimen is used. This is a new recommendation. In summary, India had made historic progress in improving access to safe abortion. Not much has changed in technological update in last decade. As providers, it is up to us to ensure safety and quality, especially in context of amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling. So this is a registration and pre-test. The one certificate will be awarded to participants on attending the training. So I request next speaker, Dr. Atima, to take the next session. Thank you.
Thank you, Meenakshi, for your wonderful talk. My talk will be on WHO Saver Toolkit. So I'll share my screen now.
Please stop sharing, Dr. Meenakshi.
Meenakshi, you'll have to stop sharing. Meenakshi.
Madam, you can share the screen now.
Yes, carry on, Dr. Atima.
Madam, please do minimize, madam. Click on this minimize button, not the close button now.
Why I'm getting this?
Madam, you're sharing the screen, madam. You
Yeah,
selected this. You selected this, so the reason it's showing in this share screen.
Okay, then I'll have to close this.
Yes,
No,
ma'am.
you open PowerPoint.
Click on the stop sharing and go to PowerPoint, madam.
Okay.
Then start sharing.
Open your PowerPoint. Stop sharing now. Yeah. Open your PowerPoint after that.
Yeah.
And then start sharing the screen. So it's while Latima is getting ready, good evening, everyone. It's really wonderful to have so many of you on the call. And I hope the entire sessions are going fine. A huge welcome to all the faculty members also.
Thank you, sir.
Suman, are you the office bearer in Ranchi?
Yeah, I'm President Ranchi Society,
Yeah.
sir.
Okay, I guess I thought as much. So what I'll request you after this meeting is over, please send us an email with details of your bank account, society's bank account.
Okay.
Okay. So
Will
that,
do, sir.
yeah, so that
Yeah,
we-
all the faculties, sir, bank account, all the faculties.
all the faculty bank accounts and also your society bank account.
Yes, sir.
Okay.
Okay.
So
Will
that
do.
we will organize, I'll send in the approval so that we can organize to release the funds to the society and to the speakers and faculty also. I think Atima's details should be there with us because she had been a faculty earlier also. I think Meenakshi and a couple of others who are not given their details earlier can do so now.
Present, sir. Mine also should be with you because I've taken
Yeah.
classes earlier also.
Yours also should be there. You have taken earlier sessions. And towards the end, my colleague here, Sriman, will be posting the post test in the chat box. So please click on it and then you can submit your post test so that we can get the certificates ready for all participants. Okay.
Yes, sir. This is for all the participants, I think, now because we have the certificate with us.
Yeah, with all the participants. Yeah, and that's about it. So all the very best to each one of you once again. And Atima, you're good to go.
Thank you.
Yeah, thank you, sir. Thank you so much. So can all of you see my screen?
Yes, we can.
Yeah, it's visible. Okay. So thank you, Sumandi. So I'll be talking on safe abortion values, evidence, rights, and respect. So this module will aim to define respectful abortion care according to WHO standard. It will also highlight how norms and stigma affect abortion care services. And there is a short video on WHO Saver resource for respectful abortion care. So what is respectful abortion care? This has been adopted from respectful maternity care recommended by WHO. And it is defined that respectful abortion care is a care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. So in simpler terms, respectful care means either you as a provider or as a patient, if you are a doctor, you need to treat, and every patient should be treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history regarding previous pregnancies, miscarriage, or abortion. Because if she is repeatedly having abortions, then that doesn't mean that she doesn't have the right to go for abortion. However, if you ever feel that something isn't right, speak up. As health professional, it is our duty to listen and support because communication is a key factor while treating a patient. Now, what are norms and stigma? This is a short video which will be showing what are norms and stigma in society.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID 19, there are new social norms that are considered COVID 19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and
Is the video audible?
No,
Hello?
madam. No, ma'am.
No. Not audible.
safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long term health effects, and the woman's health will never recover to her pre abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
So in this,
Social norms are the unwritten rules of behavior that are considered acceptable.
so in this video, you saw how norms and stigma they affect proper abortion care services. Now, in this slide, you can see that there are 7 categories of disrespect and abuse. Number 1 is physical abuse like slapping and intimidating physically, verbal abuse like not taking the consent while providing care, shouting and screaming at her, then sexual abuse, abuse of power, taking her advantage, stigma and discrimination, which can be seen in the saver videos. There are another 2 short videos on it. Then failure to meet professional standards of care, poor rapport between the women and providers, and health system condition is if not conducible, then that is also one of the category of disrespect. Now, coming to the rights of every woman has a right of freedom from harm and ill treatment. She has the right to information. She is protected under the laws of MTP, POXO Act. Informed consent and refusal is her right. Respect for choices and preferences, her dignity and quality of care. Right to timely health care and to the highest attainable level of health. Liberty, autonomy, self-determination, and freedom from coercion. Now, these are 12 domains of respectful abortion care, which has been adopted from respectful maternity care. Number 1, being free from harm and mistreatment, maintaining the women's privacy and confidentiality, preserving the women's dignity, respecting her choices, engaging with effective communication. This is very important to create a rapport with the patient. Then providing information and seeking informed consent, ensuring continuous access to support, enhancing the quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraception advice and commodity security, and lastly, continuity of care and counseling even after the service is provided. Now, this is a short video on WHO training for safe abortion values, evidence, and right.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, Use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the three P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So by now, all of us know that law has changed. Momentum has been created for respectful abortion care, and for dissemination of this law needs association and obs and gynae provider support. Foxy is the largest provider base for abortion care. Online training was possible due to COVID so that respectful abortion care can reach to all the providers. MMA uptake is increased because it is used in early phase, it is safe, and also it ensures no PCP and DT conflation. It is only the patient's safety, respect, and quality that matters more than ever. And we as health providers have an important role to play. So time has come to strengthen the implementation of new law. Up to 20 weeks of gestation, only one provider is needed, only one RMP is needed, and every patient is an opportunity for respect. And as providers, onus is on us to educate and also to reduce sex selective abortion. Up to 20 weeks, one RMP opinion. So the more responsibility lies on him regarding counseling, contraception, referral, and compassionate care. From 20 to 24 weeks of gestation, 2 RMP opinion will be required, and beyond 24 weeks, opinion of medical board will be required. From 20 to 24 weeks, these are for patients who come under special cases. Special categories like survivors of rape, minors, disabled, and unmarried women. Everyone needs unbiased care, And we need to first overcome our own biases. We need to be non-judgmental while treating our patients. And in these special category cases, need for sensitivity and judgment-free timely services is required. It also prioritizes confidentiality and safety of the women. As all of us know, respect begets respect. So as providers, we need to be very mindful of socio-cultural aspects and respect the women's choice. Name and any other particulars of women who have come for abortion needs to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of contraception has also been extended. Previously, it was only for the married couples, but now it has been extended to even unmarried couples, to all women and her partner. Respect, quality, and dignity at all types of abortion is required. So in 1970, abortion was unsafe. In 2000, abortion was safe, and from 2020, respectful abortion care is all that is needed. There are some recap questions. You'll get 30 seconds to answer them, and you can answer them in your chat box. So the first question is, according to WHO, restricting access reduces the number of unsafe abortion. Now, is it true or false? You can write in your chat box.
False.
So you were correct. This is false. Because according to WHO, the definition of safe abortion is it should be by appropriate method and trained person. And if any of the criteria is not met, then it becomes less safe. And if none of the criteria is met, then the abortion becomes unsafe. So the next question is, the MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents, guardians before she can undergo a termination of pregnancy. Is it true or false?
True.
Again, it is false. Why? Again, it's false. Why? Because it's not necessarily that parents and guardians' consent is needed. Even if any adult who is more than 18 years, they can give the consent. So this is false. But still, POCSO reporting is still needed. Abortion services should not be denied, and we need to provide bias-free services without being judgmental. Now, the third question is, 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Now, is it true or false? Yes or no?
No.
No.
Yes. We cannot be judgmental in this case. So the answer will be no. To summarize, up to 20 weeks of gestation, 1 RMP is required. From 20 to 24 weeks of gestation, 2 RMP. And beyond 24 weeks, if there is any birth defect, then there is no gestational limit. Only thing is that the opinion of medical board will be required.
कोई बात नहीं बेटा, मैं आती थोड़ी देर रुक जाओ.
So this was all about the WHO Saver Kit. We should remember that in India, abortion is legal, and let us all make it safe and respectful. Samarth means safe abortion made available respectfully throughout the health system. So thank you all for your patient hearing. So Dr. Anubi, she will not talk on contraception and counseling.
Yes, thank you, Atima, for a wonderful talk. And now I invite you to Anubi Sahai for her talk on pre and post abortion family planning counseling. You're not audible. Speak louder. There is one question, Dr. Atima. Can you please repeat the question in case of minor consent of parent is not needed or needed? Not needed. Dear Kriti, not needed, but you have to report for the POXO.
Madam, make it full screen, ma'am. Ma'am, we can't hear you.
Please make full screen, I think. Return me, full screen.
Madam, I think you locked your volume button, madam.
Dr. Anubi, are you there?
She is here, but we can't hear what she is telling. So your speaker, you check your speaker. Otherwise, Atima will have to take.
Should I call her, Sumanji?
You call her and say what is the problem. Otherwise, you can take. Atima, you have a question in chat box. Please answer. I think. Ma'am,
am I audible now?
Yes, yes. Anubi, you are audible. So please start and make your screen full. Full
Yes,
screen.
please. Is it not?
It is now. It's not full screen. Still, it is not full screen.
Okay.
Just press on the. Still, it is not full screen. You go at the bottom, left side, right side of the bottom, and there is वन टीवी टाइप का चीज उस पे प्रेस करो.
Beside 83%, madam.
हाँ.
Beside there is an 83% mention, right?
Yes, yes.
Yes.
Not that one, madam. The other one. There's some small TV kind of thing, right? Just click on that. Yes, ma'am. Just click on that.
I'm pressing it, but it is not happening.
So then go to slideshow, madam. There is a tab right out to the top, right, left.
Yes. In my laptop it is happening, but I don't know why it is not happening here.
But it is visible. So
you start. Yeah. You continue.
You can. Yeah, you can continue, and it is visible.
Yeah, it is visible.
So good evening, everyone. I'll be discussing on pre and post abortion family planning counseling. So what do we mean by counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perception. So we know this pre and post abortion counseling. It is why is this important? It is important because it is an integral part of comprehensive abortion services. It is as important as the procedure. Women may need help in decision making, and wherever needed, the spouse should also be counseled. So what are the parts of pre-procedure counseling and why does it play critical role? It play critical role because it helps women to decide about termination of pregnancy. It helps women to choose the method of termination. It ensures delivery of complete information about the procedure, and it helps women to adopt a contraceptive method. So how should we do pre-procedure counseling? First, we have to ensure privacy and confidentiality and be non-judgmental and be sensitive. We should establish rapport with her and we should use simple language which is understood by her and allow the woman to clarify her doubts. It should be a two-way communication. If she has made up her mind for termination of her pregnancy, we should access her for her procedure. So relevance of peri-abortion family planning counseling, why is it important? We have to explain her that after the abortion, there can be quick return of fertility and that minimum of 6 months gap should be present before next pregnancy. This time is opportune for contraceptive acceptance and it also has health benefits and better future pregnancy outcomes. 90% of abortion-related maternal mortality can be prevented by ensuring contraception. So pre-abortion family planning counseling, when we have to start this on first visit or first consultation. We can make it an exception if she's in a lot of grief and she's not ready to listen to what we have to say and what to counsel. We have to tell that it is important because after abortion, the return of fertility can be as early as 10 days and it can be up to 4 weeks. And we should help her with the choices and it should be method specific counseling. And we have to see high risk behavior, like if she is eligible for which type of contraceptive method. If the woman is not willing for any contraceptive method, we should not, like we do not have to refuse MTP. We have to try and counsel her after the procedure. If she is still not willing, we have to call her for follow-up in a week's time and counsel again. Assessing suitability for post-abortion contraception, general guiding rules. When we have to start contraception, we have to see that the abortion process is complete. There is no existing infection. There is no injury to genital organ and chances of fresh pregnancy is ruled out. Post-procedure counseling, it plays a critical role as it ensures woman has understood precautions and care needed during post-abortion period, opportunity to counsel for contraception in case not previously accepted, and it reinforces the need for continuing the use of contraceptive method chosen. So how should we do post-procedure counseling? We have to continue to ensure privacy and confidentiality. We have to reassure her in case of any problem, and we have to repeat the information about post-procedure care and danger signs. So in post-procedure family planning counseling, if the woman has already opted for family planning method, then we should appreciate her choice. And in case she has opted for IUCD or injection medroxyprogesterone acetate, we have to put it like immediate care. We have to put it. If she has opted for oral pills, then we have to explain her that it will be an ongoing process and she has to take the tablets. Follow-up protocol, we have to ask her to follow up as per the contraceptive method she has chosen. It has to be continued until and unless she wants another issue, and we have to give her cards for follow-up. If the woman is like she has not decided, then first of all, we should allay her anxiety. We should make her comfortable. We should explain her again the importance of immediate adoption, and we should help her with the choice of contraception. And we also, like, if she's still not ready to accept the contraceptive method, then we can explain her about the extended period of adoption and call her for follow-up. We should do couple counseling. We should counsel both husband and wife. And we should explain her that emergency contraceptive pill is not a method of contraception. So now we'll discuss about the different post-abortion contraceptive methods. So first is barrier methods, in which the commonly used is condom. So after first trimester abortion, it can be used as soon as sexual activity is resumed, and it is same for second trimester as soon as sexual activity is resumed. So the benefits of condom is that it has got no hormonal side effects. It can be used without consulting a health provider. It is easily available. It has got prevention against sexually transmitted infections, including HIV, and it enables men to take responsibility of contraception. The second method of contraception is intrauterine contraceptive device, in which the commonly used are IUCD 380A and IUCD 375. So after first trimester abortion, when we are doing the abortion by surgical method, it can be inserted immediately or up to 12 days after confirmation of completed abortion. And with medical method of abortion, it has to be inserted around day 15 of the process, when the uterine cavity is empty and complete product of conception expulsion has taken place. After second trimester abortion, it is the same as first trimester surgical method. It can be inserted immediately or up to 12 days after the procedure is completed. So IUCDs are highly effective. It provides long-term contraceptive for 5 years in case of IUCD 375 or 10 years in case of IUCD 380A. It can be provided by trained doctors, MBBS and above, ANMs and nurses after first trimester surgical abortion, by trained doctors only after MMA, and by PPIUCD trained doctors after second trimester abortion. We have to explain that there is no interference with sex, there is immediate return to fertility on removal, and there are no hormonal side effects. So third is hormonal contraception, in which the first that we'll discuss about is combined oral contraceptive. So after first trimester surgical method of abortion, it can be given immediately or up to 7 days. And with MMA, it can be started on day 3 of the dose. Like when we call her on day 3 for misoprostol dosage, then we can start her with combined oral contraceptive. And if it has not been given, then it can be given till like day 15 of the process. And second trimester, it is the same as first trimester surgical method. It can be given immediately or up to 7 days after abortion. So COCs, they regulate menstrual cycles also, the additional benefit. It can be provided by all health workers after first screening by trained provider. It has got no interference with sex. It offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign disease such as fibrocystic and fibroadenomatosis. But it is not suitable for women who are breastfeeding babies less than 6 months old. The second that we'll discuss in hormonal contraception is long-term injectable, that is medroxyprogesterone acetate injection. So after first trimester surgical abortion, it can be given immediately or up to 7 days. And with MMA, it can be started on day 3 with the dose of misoprostol. And after second trimester, it can be given immediately or up to 7 days after abortion. It is highly effective. Confidentiality and privacy is maintained. It can be provided by doctors, MBBS and above, Ayush, ANMs, nurses, after screening by the doctors for the first injection. There is no interference with sex, no effect on the quality and quantity of breast milk, no estrogenic side effects. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine cancer. Then we come to permanent methods in which female sterilization, we'll discuss first about it. So in first trimester abortion, it can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. Both mini-lap and laparoscopic sterilization can be done. And if we have given medical method of abortion, then it can be done only after the first menstrual cycle. The same with second trimester abortion, mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in absence of any infection or severe blood loss. But we have to take care that laparoscopic sterilization is not recommended in second trimester abortion. We have to wait for her next menstrual cycle, and then we can only go ahead with laparoscopic sterilization. Permanent method of contraception, they are highly effective and immediately it is effective. There is no interference with sex, no effect on breastfeeding. There is no long-term side effect, and it offers protection against ovarian cancer. And vasectomy, it has to be performed on males. It is independent of the timing and procedure of the abortion, and it is very effective. Permanent method of contraception, no interference with sex, no long-term health risk. Couple must use another method of contraception for 3 months until the sperm count vanishes. Sperm vanishes in the semen. So this is the gist of what we have discussed for contraceptive methods with MMA. So we can see here that all the hormonal preparations, whether be contraceptive oral pills or injection medroxyprogesterone acetate or centromine, it can be started on day 3 of when we call her, when the misoprostol dose is given. And we can see over here that combined oral contraceptive pills, it can be given till day 15 when we call her for the third follow-up. IUCD with MMA, it has to be inserted when we call her up on the day 15, when we have to ensure before inserting IUCD that uterine cavity is empty. Then contraceptive methods with vacuum aspiration. So here we see that combined oral contraceptive pills, it can be started immediately and it can be given up to 7 days. It is the same with injection medroxyprogesterone acetate centromine. IUCD, it can be given and immediately it can be inserted, and it can be inserted up till 12 days after the abortion is completed. And tubal ligation can be done after vacuum aspiration in first trimester abortion. So now we come to sexual and reproductive health services, in which teleconsultation is the upcoming area. So what service provision is provided? We have teleconsultation now, telecounseling, teleguidance, telereference, and telelinkage. So technological information, education, and communication for purpose, we have website Hamdo, social media, we have Ask Tanu, YouTube, infographics, helpline, and there are various patient education platforms, including that of WHO, Ministry of Health and Family Welfare, and RCOG. So what are the strength, weakness, opportunity, and threat of teleconsultation? The strength is that now COVID era, it has been a very prime thing in COVID era because the movement was restricted. So through teleconsultation, the access has become very easy. It is approachable throughout the process. Confidentiality can also be maintained, and awareness can be done. It spread out questions and answered at ease. Weakness is that it lacks the face-to-face communication, and demonstration which is done face-to-face is lacking there. So what are the opportunity? It provides privacy and comfort with like sitting at home, we can consult. It is cost saving and the number of visits is cut down. The threat is that misdiagnosis can be done many a times and there can be missed opportunities for different diseases. So applicability of components in comprehensive abortion care. So for assessment through, if we are doing through teleconsultation, we have to first confirm the diagnosis, and through that we can also counsel for contraceptive need. Counseling can be done through video conference or Zoom, and follow-up has to be done by hybrid services. Like after confirming the diagnosis, one visit can be done for doing the surgical abortion. MMA, 3 visits can be reduced. 1 visit can be done for giving the drugs, and then follow-up visit can be asked to do. So the key messages of this session is that we have to realize the need of post-abortion family planning services, and we have to bring both the couple, both husband and wife on board and strive for 100% coverage. We have to capitalize on the basket and applicability in post-abortion period. So, and we have to include the technology. The scope for entry in CAC services is wide, and but there is concern of policy malpractice, service cost, and access to common man. And adolescent reproductive health needs both online and offline approach. So once again, repeating, certificate will be awarded to the participants or attending the training and submission of registration, pre-test, post-test, and feedback. Thank you for your patient hearing. Thank you. Thank you.
Thank you, Anuvi, for a very informative talk. Now with this, we end our session, and all the participants are requested to fill the pre-test and post-test right now so that you will be given the certificates. So, admin, please display the post-test.
I've shared the link in the chat box, madam.
Okay.
Click on the link, you redirect to the posts and feedback. You don't need to stay in the meeting also. It's another page, you will be directed to.
Okay. So, I can, we all can exit then?
Yes, madam. You just click on the link, or you can just copy that link and you can do it later also.
No, we have received the certificate. So
yes, but not for the participants. I'm saying, madam. Yeah.
Participants, they can go to the chat box, see the link, and they can fill the. Okay. Yes, the link is there. I can see. So please fill the post-test so that you will get the certificates. And thank you everyone for joining us today. It was really a very informative program. We all have been benefited. So with this, we'll leave the meeting. Who don't have the faculties who already have the certificates can leave the meeting. Thank you.